Can everybody hear me okay?
Yes.
Amazing. Okay, so your maternal history. This is a 32-year-old lady who is a gravida 1 paranaught with a BMI of 23. She had a knee operation in 2011. Active genital herpes and pneumonia as a child is really her only medical history. She was low risk at booking. Came in at 28 weeks with her first episode of reduced movements. At 36 weeks, at her birth plan check, she was found to be large for dates on her gap chart. They found polyhydramnios of 13.3 centimeters, cephalic presentation, placenta posterior high, and the estimated fetal weight on the 97th centile. She was then sent to the GDM team for weekly BM monitoring, which was all completely normal. 3 days later, came in to triage for a CTG after a query D cell on the fetal monitoring, but all of that was normal. 37 plus 3, she had another scan. The polyhydramnios had reduced to 9.9 centimeters, and the baby at this point was well over the 100th percentile. I mean, 2 boxes or 3 boxes above it on her gap and grow chart. So the plan, due to the risk factors, was for an induction of labour at 38 weeks. This was her admission CTG on the 12th. So this is when she's 38 weeks exactly. So they turned the Dawes-Roman criteria on and it met within the first sort of 10 minutes. But nice baseline of sort of 140 here. As you can see, some sort of accelerations and I would say good variability. I think this one can, oh no. So this was at sort of 2:53 o'clock that this CTG was taken. At 15:34, she had an examination. The cervix was found to be closed at this point, and a propus was inserted, so her induction was then started. As you can see, still remains nice, stable baseline, good variability. There's nice accelerations as well. Were you happy with this CTG?
Yeah, I think it's okay. Yeah.
Beautiful. So she had another CTG at 21:20 in the evening, sorry. CTG was normal. I haven't included them all because there's so many and I think we'd probably be here till about 10 p.m. We're now on the following day, so the 13th now, and she's 38 plus 1. No CTG was performed between 21:20 and 07:30. So just as a reminder to anyone that we're having to anyone that's having an induction, we need to ensure that we're performing these CTGs 4 to 6 hourly, depending on their risk factors. The fact that this was left for, well, around 9 hours, if not more, is quite concerning, but I have fed that back to the midwife. And then she had another CTG at 13:40 on the 13th, which was also completely normal. As you can see, baseline is sort of 130 here. Propus was removed. Let me just get rid of that from my screen. Propus was removed at 17:15. There was a delay in getting the propus removed just due to another transfer for another lady. Cervix was 1 centimeter. And she wasn't given any further prostaglandins because she was sort of contracting to 2 to 3 and 10. They were tightening. She was coping very well with no pain relief at this point. So the decision was made to sort of continue and see how things went on. This is now the 14th. We had 2 more CTGs overnight, which were both normal, and then this is now the following day. So she's now 38 plus 2. Baseline remains as it should be, sort of that 130, 140 mark. Still got presence of accelerations, good variability. I'm not really sure what was going on with the TOCO here, because it doesn't appear to be picking up anything. I don't know whether it was put on wrong or maybe it had flipped or something on the monitor. But yeah, just to make sure there's a sort of take-home message that we do make sure that they're on properly, because it looks like she's not doing really anything. But at this time, she wasn't reported to be contracting at all. At 9:15, her cervix was found to be closed, and she was given 2 milligrams of prostin. So we're now day 2. Still happy, everybody?
Yes. Yes.
Yeah, perfect. Me too. So again, we're still going on with multiple CTGs. This one, sorry, was at around 9:15 in the morning. She had another one at 12:30, which was normal. Another one at 4:20, which was completely normal. Then she shrunk, nice clear liquor. Half an hour later, she was examined and found to be 1 to 2 centimeters dilated. She was then given some pethidine as the contractions were picking up to sort of 2 to 3 in 10 at this point. And then not long after the pethidine, she progressed really, really well and got to 4 centimeters within the space of less than an hour. Again, there was a delay in some transfer just due to activity. From what I can sort of understand of the documentation, but also from like daily sheets and whatnot, the activity on labour ward on this particular day was very, very, very high. So just bear that in mind with our human factor element. So it's now the evening. She's now 38 plus 3. Sorry, 38 plus 2. She's requesting an epidural. However, the anaesthetist is doing another epidural and then ended up getting rushed off to theatre. So there was quite a big delay in getting her an epidural at this point. What do we think of the CTG now? Anyone want to comment? Okay, so from what I can see, it looks like we're getting some possible variable decelerations. Those nice short, sharp up and down decels, also baroreceptor decelerations, as we will be moving to that physiological approach within this year, most likely around sort of April time, I think. So yeah, we've got some shoulders on those decels as well, which gives us a really good reassuring sign that this is normal physiology for this baby. But we're just going to keep a very close eye and make sure that we're assessing progress. CTG continues. This woman's been unable to pass urine and actually open her bowels for quite a long period of time. I think she wasn't able to open her bowels for around 2 days while she was admitted to the unit. So just sort of bear that in mind when it comes to sort of progress and whatnot. An indwelling catheter was inserted just because she was unable to pass. And 100 mils of concentrated urine was drained. It's not really reported how much her fluid intake was over this sort of time, but just to add that one in there, making sure we're ensuring all of our women are well hydrated and passing urine regularly, specifically as well in those early stages of labour. And as you can see as well, observations all nice and normal there too. Anybody like to comment?
The baseline is still stable with good variability, so happy to continue and examine 4 hours from last examination. As you said, paying attention that she's not been hydrated very well. So that's the only thing I'm keeping in mind at this stage.
Perfect, yeah. So just wanted to add this one in there. For those of you that have attended any of my CTG study days for student midwives and for midwives, this to me gives me high blood pressure. For people that write through the CTG when things are going on, there is a button that we can use on the Huntley machines where we can manually type in what's going on at the time. So then it comes up nice and neatly at the bottom. Some midwives even highlight it just because it makes it an awful lot clearer. But yeah, please, guys, if you are putting a woman on a monitor or anything's going on in the room, please just document it neatly and not through the middle of the CTG, because it does make it more difficult to actually interpret. At 21:45, she was found to be 5 centimeters dilated with a presenting part at -2. And she finally got her epidural at 21:50. Observations still remain within that normal parameters. Obviously, it's quite difficult to see, but would anybody like to comment on this one, or are we still happy to continue?
Still happy, I think. The baseline's stable. There's a couple of barrows, but overall it looks fine. Yeah,
absolutely. I totally agree with you. Cool. So we now move on to a bit more clearer monitoring here. At 22:11, this is your CTG. Now, this is when I start to think, okay, where's our baseline sort of happy at right now? Looks like from this sort of trace here, I don't know if anybody else would agree, but the first deceleration looks much more barrow, but the second one in that sort of middle block there looks a little bit more chemo-y to me, considering it actually, by the time it starts to go down from the previous baseline of like 130 to recover it, it's actually down for maybe 2 minutes or so. And it looks like the baby's possibly starting to get a bit slower to recover. But it does pick up back to baseline nicely, and the variability still remains normal. At this point, the registrar, I believe, was actually in theatre. So the consultant came and did a review and said to reassess examination in 4 hours, which would be at 1:45 a.m. And if no progress at that point, then to start some Synto. Happy with this as a plan? I think I heard a yes.
Yes.
Perfect. Yeah. So we continue. Observations remain normal. Again, having a sort of variable decel there, but remains back up nicely to baseline, and variability remains good as well. Nice and stable. It continues like this for a wee while before anything else happens, so we'll just keep going. Again, nice stable baseline, good variability. We're still sat at that 130 mark. This baby's not really showing us any signs of distress or hypoxia, which is really reassuring. And she's sort of contracting at around 2 to 3 in 10. So we're now on the 15th. So she came in on the 12th. So we're now 38 plus 3. Fresh eyes was performed and noted as shallow variable decels. So it was reported as a suspicious trace. Anybody agree or disagree? Would we say these are barrow or chemoreceptor decelerations?
They're more chemo, and the bit to the right looks like it's a slightly unstable baseline, but it's hard to say in terms of where it goes off the screen.
Yeah, I do agree with you there. I think that's Maddie, isn't it? But yeah, it looks like, so baseline sort of 130, definitely a chemoreceptor deceleration at the end, because it is taking sort of 2 to 3 minutes to get back to the baseline there. The variability as well, I'd say in this one is significantly reduced in terms of what it was in the previous slides. But yeah, just something to be aware of, make sure it doesn't continue for too long, and it could just be babies just cycling. Cool. I continue. 0015, she's moved to left lateral just as a position change to try and improve the variability.
Sorry,
also,
Cara, I missed how many centimeter are we?
5.
5
okay.
centimeters.
Sinigi, what do you think?
Here based on the previous one, I feel like still no action is needed yet. Yeah.
Perfect. Excuse me. Okay, we keep going. Registrar at this point comes and does a review, introduces himself to the woman because they've been in theatre, I think, for the majority of the evening so far, and says that the CTG is improving. I think would we agree or would we disagree? The
I
only
think
thing,
given the stable baseline, Cara, we're happy to continue.
yeah, perfect. The only thing I would sort of say in this one, which was the reason I chose this one to review, is the fact that in the last sort of 2 slides, it looks like what our favorite thing, which is accelerations with the contractions, as you can sort of see if I go back one, but I'm continually doing research into this, and I'm not really getting anywhere with it. So if anybody finds any additional studies other than the ones I found, I would greatly appreciate it. But what I would say is that something that was taught by one of the consultants at Kingston was you never have accelerations with contractions. They're most likely recovering from either a decel or they could be maternal pulse. And if you do look quite closely, although we are getting a bit of a magnifying glass out here, which I always say we shouldn't really be doing if we're trying to sort of classify CTG. At the end of the day, if it's not clear, then it shouldn't necessarily be counted. But it does look a little bit like these accelerations are those little recoveries from the D cells. I don't know if I'm seeing things or if anybody disagrees or agrees with me here, but yeah, and I'd say they look slightly more variable with maybe a little bit of overshoot or something.
I slightly, Cara, in medicine, I slightly disagree with the statement that ever says you never, because
Yeah,
like occasionally you see acceleration during contraction. Yes, you need to be aware that it is not the norm, and you might be having maternal, and you might, and yes, you need to be very vigilant. But at the same time, it is not a never. You say almost always something like that.
yeah. This is something that has caused quite a lot of debate on all of the sort of additional study days and things that the majority of us have participated in. And yeah, I mean we've reviewed multiple cases before where you can clearly see that the fetal heart rate is accelerating with the contraction. I don't know if I'm thinking too much into it and whatnot, but yeah, it's just something that I notice slightly differently about this one in comparison to some of the others, because yeah, we can never say never, can we? And it's always a case of sort of seeing what else is identifiable on the trace.
But Cara, I think I know that so far there's no research to tell us exactly what they are, but mainly the generalized consensus is that it is like a hemodynamic changes. So it does not reflect really chemoreceptor changes, and this is I think the reassuring bit. So I know, like the same consultant who said that, I had a discussion with her, and so far they hate the term, like it's a partial cold compression, or we have to agree that we still don't know what they are, but at the same time they don't reflect chemo changes. They're more kind of like a hemodynamic baroreceptor type of changes, and this is what we're looking at.
Yeah.
But we still can't really pinpoint exactly what's going on, so that you're getting, is it the veins are getting compressed, and I think this is kind of like a area or niche where further research will definitely come in the next few years, isn't it?
Yeah, I think so, and I'd like to hope that at some point in the not too distant future we'll have a much better overall picture of what exactly they mean, because even though, you know, the research at the moment sort of suggests, yes, they could be baroreceptor changes and whatnot, there's also a completely alternative piece of evidence that says that this could be a case of fetal panic, fetal low blood pressure, and like internal bleeding within a fetus. So it's really quite confusing, which is why I always like to include them, because, you know, I'd like to think that eventually we'll get to a point where someone will have a better answer as to what exactly they mean, or what other parts of the CTG may differ, and how the differences could I'm not wording this very well. Basically, if something like increased variability with these accelerations with the contractions is different, and what that means in comparison to someone that's, say, got reduced variability and accelerations with contractions, if that makes sense at all. But yeah, hopefully we'll get to the bottom of it at some point. I will continue.
I think Dagmar was, I don't know whether she raised her hand or was a comment. She's with us on the call. Maybe she wants to comment.
Bear in mind, I have only kind of just joined, so sorry for the interruption. I didn't make it in time. I've just returned. Two things that I wanted to kind of say. So one is about your kind of research. I do not know what your research is. There's one kind of helpful review article about spurious accelerations, and it essentially looks into kind of different reasons why accelerations can occur. And generally speaking, there is, and I'm totally with Naguib here, there is no such thing as the always in medicine. There never is, no? I think it is just always a recurring topic, because there used to be nice guidances that said, for as long as there is essentially accelerations, essentially that's a happy trace. And that is not true. So because it can look like an acceleration without being truly one, and that is somatogenic baby moving kind of part. And that's particularly dangerous in the second stage, where you can very easily pick up the maternal pulse because the baby's head is further down. And then you're reassured, but you're actually kind of not even monitoring the baby. And there are many HSIB cases, former NHS resolution, former, the kind of name has changed over the decades. But there are plenty of these cases about, and that is always, when you see accelerations, make sure that that is what they are. But you always look at the whole picture. So that was comment number one. And the other one is, be really careful about the use of the word baro and chemo decelerations, because I'm not sure if you're aware of all of the publications from Chris Lear. It's essentially the Australian kind of part of physiology, and they work with one physiologist and the kind of O&G team. I have no idea to what extent the O&G team is essentially involved with that, but so their kind of publications are essentially indicating that there is no such thing as a deceleration that doesn't have peripheral chemoreceptors in it. So therefore, this clear distinction between chemo and baro is probably incorrect. And so therefore, scrap that. Just call them decelerations and what they are, variable. And essentially be careful with the use of chemo bad and baro good, because that's probably not what they are.
I think Austin Ogwamadu at George's mentioned that at one of his study days recently, that all decelerations have chemoreceptor aspects in them. So actually
Correct.
Defining them is even more difficult.
Yeah, correct. So therefore, essentially, don't use the words. They are variables. So in the physiological guideline that essentially went through at least 34 different experts from, I think, 14 countries or so, or the other way around, I always forget, that doesn't use the word. So you have essentially early, late, or variables. So, scrap the other kind of bit, and don't distinguish between baro and chemo. Always look into what it tells you about the placenta, but essentially scrap the one is good and the other one is bad, because yes, they all have chemo parts in them.
Which just makes it even more confusing when we move to a more physiological approach.
just use variables. There's nothing to it. They're variables, yeah, and that's it.
Thank you, Dagmar. Okay, we'll move on, guys. So 0115, this lady has moved to a semi-recumbent position just because she's uncomfortable. And baby at this point decides, I think, that they don't particularly like that. This deceleration here, as you can sort of see, is takes around 4 minutes to fully recover back to the baseline here, but does so well, and variability appears normal following. We'll keep going because it does look quite similar at this point, and it's more the sort of action plan at the end that I think would be worth having a sort of discussion about. We continue, as you can see, still getting some decelerations with those contractions there, although very variable in terms of their sort of short and sharp. Perfect. We keep going. Anybody want to comment on this one? Okay. At 0250, she's examined again, and she remains 5 centimeters with her presenting part at -2. So 10 minutes later, Sinto started at 3 mils per hour. Observations still remain nice and stable, and as you can see, baseline still remains stable with really good variability. At 0330, deep early decelerations are reported, and the CTG is classified as suspicious. That the Sinto is increased to 6 mils per hour. I just wanted to sort of comment on this one. I get a little bit confused about deep early decelerations. I know that the sort of classification, if you like, of early decelerations can be a little bit complicated, but they're sort of much more common in the second stage of labour, just because they're mainly due to sort of head compression. But I think here we'd probably go, tell me if you disagree, but we'd probably go with more variable or sort of baroreceptor decelerations.
Yeah.
Yeah. Fabulous. We will continue. So at 0408, as you can clearly see, deceleration occurs and the emergency buzzer is pulled. This lady is then moved to left lateral position, and the plan is to stop the Sinto until the CTG has normalized. And this decel here goes on for about 5 minutes or so. So this baby's clearly not very happy at this point and is telling us, okay, we either need to tone down the Sinto or we need to move position. Through all of the positions that I can sort of recognize in the documentation, this baby is much more happy when this woman's not in a sort of semi-recumbent place. But also not really sure what's being picked up on the TOCO here, but could be that the contraction duration or strength had significantly increased, which had caused that response from the baby. We'll continue. So Sinto is now stopped at this point. We turn to right lateral, just due to this, again, this secondary deceleration, and another one here as well. And then it appears to sort of normalize again, but with arguably some reduced variability in between those accelerations. But those are all sort of reassuring signs that this baby is still well. Sinto's then recommenced at 5:10 in the morning at 3 mils per hour. And we've now got some pinkish like or stained. 530 fresh eyes, variable D cells, and this is classified as suspicious. Does anybody agree or disagree?
I don't see it suspicious, or I mean, we are still stable baseline. My concern is not CTG wise. My concern is the stopping and the starting, which happens a lot, and I do it. Like, but at the same time, what is the plan? Like this is a baby on the 97th centile, 5 centimeter twice, head is -2. I think sometimes we like to manage CTG alone again, without looking at the bigger picture.
What would your plan be, Mr. Naguib?
My plan is like if she's 5 centimeter twice now, 4 hours apart. Every time I start the CIN2 at 3 mils, it doesn't go anywhere. The head is -2. I do a good examination, and if I feel like the long term hours is not going to work, like from the obstetric point of view, there is no point in prolonging the situation, either from maternal side or fetal side. I know many people would like to give another 4 hours, then another 4 hours. I am more of, like looking at the CTG together, fetal and maternal together. I cut the story short at this point, but this is personal opinion.
Perfect.
Did they comment, Cara, if it's OP baby?
No, not from the
It's -2, but what did they say about position? Like
OA.
because we've had to it's OA.
Yeah, OA.
Okay, thank you.
Okay, we continue. Still looks very, very similar. No major changes within the next sort of hour or so, as you can see, but we are getting some variable decelerations with all of our contractions now, which technically would classify our CTG as suspicious, but nice shouldering on all of the D cells. Really reassuring sign that this baby is just physiologically very much coping with the stresses of labour. We keep going. She has an epidural top up at around 6:41, just because she's feeling some pain. But everything otherwise remains normal. Again, we're having another deceleration that lasts around 4 to 5 minutes. I think this was again due to the fact that she was in a sort of semi-recumbent position, which she would have been for the epidural top up. But again, recovers nicely back to baseline. And continues and continues and continues. Something that was taught by one of the fetal wellbeing consultants at St George's, was that babies that are under the sort of the stress of labour can continue with variable decelerations if shoulders are present for actually an incredibly long period of time, which I found very interesting, because the question being how long do we continue to go on for if she's making progress and whatnot. But supposedly, because it doesn't necessarily affect the pH of the fetus and doesn't necessarily show signs of any additional distress, if all other factors are reassuring, then babies can continue to have variable decelerations for very long periods.
But what was their documented plan? Did they give her 2 hours or 4 hours?
They gave her.
They must be kind of like a decision plan here.
Yeah. So she was. When was she? She was 5 centimeters. Sorry, she was 5 centimeters at 0250. So the plan was 650 for an examination. I think, again, just due to the ward activity, that was delayed by an hour. And then an examination was done at 07:50 in the morning by the obstetric registrar, and she was found to be 8 centimetres dilated. So good progress has been made, and the plan was again just to continue. Observation.
Just
Sorry.
where was the head? Even it was 8. Where is the head exactly?
-1 at this point.
Okay. Right.
We keep going. So day staff have now started. Still having some variable decelerations with contractions. She's only contracting sort of 2 to 3 and 10 here as well. There's some issues with the monitoring, as you can see towards the end. Synto, sorry, was someone going to say something?
I'm saying, if she was she on Synto at this point?
Yeah, she was. So she was still on 3 mils.
Thank you.
So CTG starts to go down at sort of 08:36 here. Or 08:30 a.m. Getting all my numbers confused. And then the emergency bell, I think, is pulled again. The Synto is stopped at this point due to the prolonged deceleration, and the day registrar comes in and finds her to be 9 centimetres dilated in an ROA position and remains presenting part at -1. An FSC is also applied here just to get a better monitoring. This was what I found quite interesting, is the fact that, I don't know if people remember me saying that this woman would be quite constipated for a prolonged period of time. And when they did an ultrasound scan to confirm the position of the baby, this is something that I've never heard of before, but they could actually see fecal matter on the ultrasound scan. So a bedpan was provided and lactulose was given to try and help this woman open her bowels, and hopefully that would have an impact on fetal descent as well.
How long does lactulose need to work?
Lactose, as far as I was aware, is about half an hour to an hour before it starts to get.
Lactulose.
Yeah.
Okay.
I think
Oh,
I think Cara, maybe the one doing the ultrasound is doing transperineal ultrasound. It's not transabdominal. Okay. And that's why they are seeing the fecal matter. So that's one. Number two, if I am worried that she is having fecal loading, I would give an enema rather than a and in some situation I give the enema and then she delivers. But I mean, if you want really to get the fecal matter out, is not lactulose, you do an enema.
I did think that was a little bit strange, and yeah, now that you've mentioned that, that does make an awful lot more sense, because I remember sort of reading through these notes and thinking that's a little bit odd, but I don't know if it was clearly documented that this was did you say perianal?
No, transperineal, and the one
Transperineal.
yeah, the one person who does it very well in our unit is our lovely Candice, because she does it all the time with Mr. Sultan in the Urogyne.
Right. Yeah. Yeah. I've seen that before, but yeah. The client at this point, though, did actually feel the need to open her bowels, which was good. So bedpan was given, and she was supported to do so. At this point, obviously, we can see a clear baseline rise as well. So we're getting to the point now where baby's sort of showing signs of a gradually evolving hypoxia. We know that our decelerations are now getting longer. They're getting deeper from the baseline, and then this baby's now compensated by increasing the heart rate to try and to compensate better. And I'd also argue here that this was some reduced variability as well. However, not necessarily concerning for this at this point. However, I know that they had some difficulty with monitoring as well with the FSCs that we're currently using. So yeah, slightly more difficult, but the plan going forward was to just continue because she'd made progress. We continue. So baseline's now at least more than 20% more than what it was originally. So baby's showing us a gradually evolving hypoxia. However, we're still getting some accelerations present, so reassuring factors are still there. Baseline is stable and variability remains normal. And the plan again is just to continue monitoring and hope that she does progress further within her labour. We continue. At this point, pre-meds were given because the impression was that this lady was either going to be delivered due to the high head, that this lady was going to be delivered possibly in the operating theatre or be taken for a cesarean section if progress was not made. And again, she was moved from right lateral to left lateral continually to try and improve the CTG. But baseline does look like it's returning back down to normal, which is good. At 11:05, a different registrar comes in to examine, finds her to be 9 centimeters dilated. However, this client declined cesarean section and wanted to allow more time before deciding to go to theatre. So those wishes were obviously granted. About half an hour later, a consultant becomes present, examines this woman as well, finds her to be 8 centimeters dilated. So the decision was made for a cesarean section for failure to progress, with gradually evolving hypoxia compensated as the sort of definition of the CTG. Are we all in agreement?
Yeah, I agree.
Yeah. Do we agree with the plan?
Yeah, we agree. Yeah.
So the decision was made at 11:35. We keep going, I think, due to delays with another emergency. And then we move to theatre at around 12:17. Knife to skin at 12:52, knife to uterus at 12:56, and delivery at 12:57.
How big was the baby and what's the blood gases? So
Does anybody want to guess?
4.2 kilo with normal gases.
Okay, anybody else?
This baby's problem was definitely not hypoxia, so therefore it would have normal gases and didn't get the initial history about kind of size, but yeah, heavy baby.
I'm going to guess 3.8 and 7.3. 7.257.
4.1 and yeah, normal 7.3.
Perfect. Baby was 3.4 kilos on the 72nd centile. So actually normal growth, normal weight. APGARs of 9, 10, and 10. Gases were completely normal, as to be expected. but yeah, I think the sort of progress in labour was down to the fact that the Cinto couldn't really be put up much further than that 3 mils per hour. So she was only contracting really sort of 2 in 10 for around 12 hours. 2 to 3 in 10 for around 12 hours. But whenever they put it up to 6 mils, they got more decelerations. And the progress may have been affected quite greatly by the fact that she was so impacted. And hadn't been able to open her bowels for sort of 2 to 3 days prior to delivery.
I mean, they couldn't, you know, they couldn't have put the Cinto up anyway. So yeah, I think they did the right thing. But maybe,
agree.
yeah, but maybe the, you know, um, uh, for her, because we cannot see the patient herself, so she might be a small lady. So 72 centile for her as well is quite big. So yeah, so that's why the baby couldn't come down.
Yeah, absolutely. So quite an agreeable case this evening. We have excellently managed to not have any term admissions since the 8th of January. Touch wood. So I think that's why I'm low on